Colorectal cancer has always been thought of as an old person's disease. Now, studies have shown that a person born after 1990 is 2 to 4 times more likely to develop colorectal cancer compared to a person born in 1950. And it states because of this, it's very important to get screened at 45 years old. Let's talk screening for colorectal cancer. Who should get screened? What are their options to be screened?
Yeah, absolutely. And I'm glad you mentioned what we're observing in terms of younger people being diagnosed with colorectal cancer more often than we saw in previous generations. I did want to point out that, that's not strictly hereditary or genetic, at least as far as we understand right now. I think there's many groups that are trying to figure out the why of that observation, but it's one of the reasons that now the recommendation is for everyone in the general population. So we're not talking about people with genetic risk or hereditary risk, or even those with family history of colorectal cancer. They would have slightly different recommendations, but those who are at general population risk for colorectal cancer, that they are recommended to start some type of colorectal surveillance starting at age 45.
This is Genetics for Healthcare, a podcast for patients.
Today, we have Dan Dry Doc Shockley, U.S. Navy veteran and cancer prevention warrior. And we also have Rachel Hoden, genetic counselor and associate professor of genetics at Stanford University. And they're going to talk to us about genes that increase the risk of developing colorectal cancer and diseases of the gastrointestinal system. Dan, first of all, thank you for your service.
Thank you, it's good to be home.
Dan and I connected, Rachel, on Instagram, of all places. Shout out to our Instagram followers, by the way. You can connect with Dan at Dan Drydoc, and you can also follow us on Genetics for Healthcare. But I was fortunate enough to connect with Dan live and hear his story. And I learned that he carried a gene mutation that causes colorectal cancer predisposition syndrome called FAP. And Rachel's going to tell us more about that shortly. But according to gene reviews, depending on the form of FAP, if left untreated, it has a 70 to 100% lifetime risk of developing colorectal cancer. Colorectal cancer is the fourth most common cancer diagnosed in the United States. And according to SEER data, there is an estimated over 154,000 new cases of colorectal cancer diagnosed in the U.S. this year, 2025. The good thing is colorectal cancer is considered one of the most treatable cancers in the United States when caught early, with 5-year survival rates over 90%. And according to the Colon Cancer Alliance, the average age of diagnosis of colorectal cancer is around 66, but the form of FAP that Dan has, called attenuated FAP, the average age of diagnosis of colorectal cancer is between 50 and 55 years of age. Dan, I appreciate your advocacy. I appreciate your attitude. We were talking, before we got started about like your energy and just your mindset is really motivating to me. And I really appreciate you sharing the forward actions you've taken to prevent a cancer diagnosis. So can you share with us your journey to this diagnosis with attenuated FAP?
Absolutely, Roman. So I retired from the Navy back in 2003 after serving on active duty for 22 years, 4 deployments to the Persian Gulf. And so when I registered with the Veterans Administration Healthcare System at 43, my primary care doctor said, well, when you turn 50, we recommend you have a colonoscopy. And I said, sure, you just put it on the calendar. When I turn 50, we'll schedule it. So I had the colonoscopy. It revealed 100 polyps embedded throughout my colon, rectum, and anus, and one of those polyps was creating a 80% blockage in my ascending colon. Now, when I woke up, I got sedated, and my GI doctor was standing next to me and had all these photographs he took, and he says, well, Dan, you're a little groggy, but I need to talk to you. I want you to come into my office, in a couple of days, because I need to get you over to I was in Hawaii at the time at the VA. I need to get you over to Triple Army Medical Center. I need to have you seen by the certified genetic counselor. We think you have a hereditary colon cancer syndrome. However, we won't know for sure until you have the DNA test results. So I said, okay, well, I don't know anything about this, and I'm asymptomatic, no family history. I went to see the genetic counselor. She sat me down and she said, we think you have the APC mutation, and we won't know till the results come back. I said, well, let me know what I need to do. I've been over, deployed to the Persian Gulf, 4 times, so I'm ready. Plan for the worst, hope for the best. Adapt, improvise, and overcome. So I said, let me wrap my head around this. Give me some things to read about. And there was very little. However, she gave me some good sources, and so it took 6 weeks to get the results back. I had read, the best practice medicine if you have the mutation, have a total proctoclectomy with permanent ileostomy. And so I read about that type of surgery. I read about the mutation, what I could find, and I read about what it's like to have an ostomy. Well, theory is one thing, practical application is another. And so the results came back in. I sat down with my colorectal surgeon and my genetic counselor, and I said, "Well, Dan, you have the mutation. Um, however, you don't have to have surgery, but it's in the best practice of medicine to have the surgery because any of those polyps left unattended have a 100% chance of developing a colon cancer." Now, just a side note, uh, Dr. Henry T. Lynch, the founding father of hereditary cancer research, he is credited with the discovery of attenuated FAP. Now, my genetic counselor and my colorectal surgeon were colleagues of Dr. Lynch, and at the time he was 86 years old.
Mm.
He was, among other things, the director of preventive medicine at Creighton University in Omaha, Nebraska. Well, let's fast forward to after the surgery. So 7 months after the surgery, Dr. Lynch decides to come over to Hawaii to do some academic lectures. So as you can see, there's a picture of Dr. Lynch and I together outside the University of Hawaii Cancer Center. And then that's my colorectal surgeon, um, Dr. Ronald Gagliano. And so now I get to sit down with Dr. Lynch there in Hawaii for an hour and 50 minutes to talk about my diagnosis. And he said that I had a unique case of AFAP. One, because there's no family history. So he considered my mutation de novo, and he said that 1/3 of the cases of AFAP are de novo. He said it's very well possible your mutation started with you, and I said, well, I don't have any biological children, so it's going to end with me. Now, my parents, my paternal relatives have all passed away. I'm the youngest of my siblings, youngest of my first cousins. No one on either side of the families have any colon problems whatsoever. The Shockleys are notorious for heart problems, so I'm a team player. I took it for the family, and so what I do is I share all my information with as many first cousins and with my siblings, and then they share it with their GI doctors. They said, okay, well, my relatives only have one or two, three polyps. They're benign, and I continue to give them updates as as I go through my surveillance. So
Dan, with you being, an ex-soldier, I recently talked to Kimberly Alexander. Her husband was a multiple myeloma patient and succumbed to the complications of his disease. But similar in mindset, um, soldiers, football players, programmed to ignore discomfort and pain. Looking back, were there any symptoms that you noticed that you may have dismissed or anything?
no, absolutely not. I retired from the Navy, and the military were so big, especially on deployments. We were up 18 hours a day. So when I got home, I'm so used to being up, and plus I had to help compensate the income. So I was actually working two full-time jobs from 2004 till 2012 when I had my colonoscopy, and I I didn't feel anything. I didn't know anything, and it was amazing. No, and by the way, that large mass in my ascending colon turned out to be an 8 centimeter high grade dysplasia tumor that we were able to. Dr. Gagliano was able to get the associated lymph nodes. So
And that was benign, not cancerous, correct?
it was high grade dysplasia. So yeah, it was. But thank goodness, it all happened that way, and but that's the importance of early detection, and it's the importance of colonoscopies because you can get in there and do biopsies and what have you. Um,
Absolutely.
so that's the only one I ever had. I mean, that's it. And
So,
I try to encourage my family members to have discussion with their medical team to determine what for those who haven't had colonoscopies. But I try to be a source of inspiration and encouragement. So it's the decision's all theirs, whatever they want to do, but at least have the discussion with their medical team to take the best course of action.
Rachel, Dan mentioned that you had him as a guest at Stanford for a live case presentation for attenuated FAP. What made his case so compelling? And if you can explain, what is FAP and what are the characteristics that lead to a diagnosis? Because in Dan's case, as he said, he didn't really have any symptoms.
Yeah, thanks, Roman. Thanks so much for having me. It's a great opportunity, and I always enjoy hearing Dan's story as a longtime patient, and now really I consider a friend. FAP, or kind of the umbrella term, APC associated polyposis. So APC being the name of the gene, and then understanding that there's kind of a spectrum of disease. There's very classic FAP, familial adenomatous polyposis, and then there is kind of a more attenuated AFAP type. And then there are kind of a wide spectrum. So, of course, there are individuals who are diagnosed with APC associated polyposis who have hundreds to thousands of polyps in their colon. This just very classic presentation. And then, as Dan mentioned, and as you alluded to, there's really a wide range. So, some patients have much fewer polyps and a lower, what we call, polyp burden. And the age can be somewhat variable too. Like the very classic presentation of FAP can be diagnosed in teenage years or early 20s, and patients can present with really disruptive GI symptoms, rectal bleeding. And in the case of where there's no family history, it could be completely, unknown to them why they're having these kinds of symptoms. And then there are patients who are identified to have APC associated polyposis at later ages. And so we kind of use that as describing, well, this more attenuated, what we call phenotype or presentation, where you do make a lot of polyps, as in Dan's case, but at kind of a later age. And so certainly, again, there's this wide variability. And I always enjoy hearing Dan's story. And I think because he's such a great advocate for himself, his family, and for kind of the hereditary GI community at large, I think he's a great person to come teach students about hereditary GI conditions and hereditary polyposis. So he's done a number of things in collaboration with our group. One is the live case presentation that you mentioned, where he came to talk actually to medical students. So taught by a medical geneticist who was teaching a section of a course, and had him come in and talk with medical students. He's also been really generous with his time and has recorded a lecture also for our genetic counseling master's students. So students who are working towards a master's degree in genetic counseling, who are also learning about, of course, hereditary cancer and hereditary GI disease. So, really his advocacy and what makes him so special is his story, but also just the amazing amount of time that he puts into making sure that other people are aware of these diseases.
Yeah, absolutely. According to Gene Reviews and the National Cancer Institute, FAP accounts for less than 1% of colorectal cancers. And it's in that mutation, as you say, in the APC gene, is in every cell. So I can imagine it can influence the development of other types of cancers. Is that thinking the right way about that?
So great question. So in the general population, it's somewhat common to develop a polyp. So just kind of starting there, like the average person, at least 25% of people will develop at least one polyp in their lifetime. And those polyps, that kind of first genetic issue that causes the polyp is usually an APC mutation. So in the tissue itself of the colon. And so you can imagine that for your average person who in every cell of their body, the APC gene is working correctly, they are having a random event that knocks out that gene. And so they're developing a polyp. And it's a little bit more complicated than that. And I apologize to my molecular colleagues if I'm misrepresenting some of that. Certainly, there's other genetic mutations that occur as well. But so that APC gene is just so important in the normal tissue of the colon. And so, exactly as you said, for individuals who have hereditary disease, like an APC pathogenic variant, that's in every cell of their body. And so they have one copy of the APC gene that is not working in every cell, and they have one copy of the APC gene that is working. And the working copy cannot completely compensate for the non-working copy. And so, as you can imagine, if you've already knocked out one copy of that APC gene, you're going to develop polyps at a much faster rate than someone in the general population. And so that's really the distinction of the disease, is this formation of polyps. And then again, just statistically by chance, the more polyps you make, the more likely some of those will go on to develop a colon cancer or colorectal cancer. And so just, you quoted some of those statistics from gene reviews. Depending on the mutation and depending on the age of onset, the risk for colorectal cancer without any intervention can be, close to 100% in some cases. There are other hereditary colorectal cancer conditions that work by a different mechanism. So they're not specific to the APC gene, they're specific to other mechanisms of disease like Lynch syndrome or juvenile polyposis syndrome or Putz-Jaeger. And so they have a different underlying molecular cause.
So I'm going to double click on that in a minute. And Rachel, I really appreciate you delivering this information in a way that we can receive it, because most of our listeners are decidedly not medical folks. There's someone who is their mother, their sister, their brother, their cousin has been diagnosed with a colorectal cancer, and they might be listening to this. So I want to double click into those other genes and possibly the function of genes in a second. But you mentioned Lynch syndrome, and Dan was talking about the opportunity to sit down with Dr. Henry Lynch. Now, for those who may not know, Dr. Henry Lynch is a generational legend in medicine. He is a world famous cancer researcher and is considered the father of hereditary cancer research. He pursued the etiology of cancer, what causes it. So when you go to the doctor and they ask, hey, what's your family history? And then the seeking of screening, the interventions to disrupt the pattern of disease, cancer in families, that came from Dr. Henry Lynch. His body of work and mentorship has made it possible to find ways to identify people at risk for developing cancer and ultimately prevent illness from happening. Dan, you had the opportunity to learn from him about your condition. Can you share, what did you learn? Like in a couple of hours, it's like, like a fanboy, my brain would be blown. But what did you learn, and how had this impacted your quality of life and your approach to your healthcare, especially regarding the surveillance of your condition?
It's amazing. I can, like it happened yesterday. What happened is, little did I know that my genetic counselor and colorectal surgeon had been colleagues of Dr. Lynch through the decades. So once I got diagnosed, they shared with me about Dr. Henry T. Lynch being the doctor who's credited with the discovery of attenuated FAP. And then they said, well, he's going to be coming to Hawaii. So 7 months after my surgery, Dr. Lynch came, and at the time he was the director of preventative medicine at Creighton University in Omaha, and being the founding father of hereditary cancer research. So I wanted to read a little bit about him. I only had a couple days to prepare for it, and I found out that at 16 years old in 1944, he dropped out of high school and joined the Navy, and he used a relative's ID card to get in. After a couple months he was in, they found out he was underage. Said, "Oh, just go ahead. You're already in. We'll let you serve your 2 years." So he served in three different theaters. Got out 1946, and while he was in the Navy, he was boxing. And back in the day, they called it smokers. They would have boxing tournaments on the ships, little sidebar thing, the sailors would do. And so he started boxing when he got out of the Navy, and he married his neighborhood sweetheart. Remember, he didn't graduate high school. He married his neighborhood sweetheart, Jane. And Jane said to Henry one day, "Henry, this boxing gig isn't going to cut it. You're going to have to find yourself a job." So he went to the VA and he started getting assistance to go to school. And as the years went on, he ended up studying clinical psychology, studied genetics, and in the mid to late 60s, he was actually a medical doctor, a proctologist. So he had a lot of patients that were passing away of colon cancer. He suspected that colon cancer may not just be environmental, it may be hereditary. So he started applying for grants to do research, and they kept turning them down, saying, "Henry, you're way off." He goes, "No, I think I'm on to something." And hey, Lynch syndrome's named after him. And in 1984, he received a grant from the American Cancer Society to conduct testing, which 6 years later led to the discovery of attenuated FAP being a subvariant of FAP. Now, he shared with me that he estimates that less than 0.03% of the global population were impacted by attenuated FAP. Now, that's what he shared with me personally. Now, let me go back to when I met him. So he came to Hawaii. He had one lecture at the University of Hawaii Cancer Center. So my genetic counselor invited me to one of his lectures. She had me go to Tripler Army Medical Center, and she had the chief hematologist oncology doctor personally drive me down to the university, to the cancer center. So my genetic counselor was coming down a hallway with Dr. Lynch, and I was informed to walk ahead. And so she personally introduced me to Dr. Lynch in private before his lecture at the cancer center. And then afterwards, we sat down. So an hour and 50 minutes is an hour and 50 minutes I will never forget. And I had my copy of my DNA test results, my pathology report, and we sat down and he said, "Well, Daniel, you have a unique case of AFAP." And I shared with him about he knew about the family history. There wasn't any. He goes, "It's very well possible that your mutation started with you." And I said, "Well, I don't have any biological children, so it's going to end with me." And he said, "Well, I recommend you have your routine endoscopic surveillance. And if you'd like, you can send the pathology reports to me. I'll provide my feedback and insight. Just continue this as the years go on." And it was just amazing, to have this have an open door to Dr. Lynch. And so I realized that this diagnosis is rare, and it caught all my family off guard. I'm the youngest of my siblings, youngest of my first cousins. My parents and maternal, paternal relatives all passed away. So we have no idea, absolutely no idea, where this came from. So that was even more intriguing to me to continue to ask lots of questions. So, but having an open door with Dr. Lynch, through the years was just absolutely amazing, and the world-renowned leader. And I was born in 1960, so when he passed away in June of 2019, my entire life up until that time, he has been devoted to hereditary cancer research. So I thought the least I can do is to educate the medical students about my journey This way, they'll have it for the rest of their medical careers and the rest of their lives. And, I go back to my GI doctor was 70 years old when he performed my first and only colonoscopy. After my diagnosis and surgery, I had a follow up with him, and he says, Daniel, I was going to retire 6 years ago. And I said, why you didn't retire? Because you needed to save my life. And here, Dr. Lynch at the time was 86. Okay. So there's lots of things going on through the decades behind the scenes, no pun intended, with the GI community. And if it wasn't for my GI doctor attending these various conferences, I mean, how would he have suspected that this was FAP, or AFAP? So immediately having me evaluated with genetic testing was brilliant. I mean, but it all goes back to what Dr. Lynch has been doing for the many decades prior to this. Um, that was that the GI community was able to pick up on this. And this way, this is where I come in to share my journey with the medical students, whether they're going to be cancer researchers, medical geneticists, cancer surgeons, even genetic counseling. This way, they have my information, and I do this. Virtually, I do it internationally. But this is my way to continue his legacy, to educate the medical students about attenuated FAP on the importance of early detection in hopes of saving lives. And, it's just, this is the least that I can do. I look at that movie, it came out about 25 years ago called Pay It Forward. My life is like that. And I do everything gratis because I look at what Dr. Lynch has done. It's, saved my life. And then I was at Stanford as a patient 4 years ago because the mutation, there was a 3 centimeter adenoma in my jejunum, beginning of my small intestine, that is directly related to this mutation. And if left unattended, it could have reached my pancreas. So the VA referred me to Stanford University, which is where I have ties with now. So I had surgery, and I knew the older I got, once I met Dr. Lynch, that I would be a candidate for a surgery, which I thought was the Whipple procedure. However, in the last 25 years, there's a newer technology, and I had a pancreas sparing duodenectomy resection surgery. I know that's a lot to digest. So I had one of the nation's leading pancreatic surgeons at Stanford, and I had they removed 60 centimeters of my duodenum or duodenum, depends on who you talk to, what day of the week it is. They took my gallbladder out, and he inserted a 5 French pancreatic stent. And I continue to be asymptomatic. I'm fine. I've actually, since that surgery, I've actually gained 45 pounds. And that's just because, I've always felt healthy. My endurance is a little, slow, but that's okay. But I'm able to gain weight because I was down to like 145, 147 pounds. I feel great. And I'll be a patient at Stanford for the rest of my life. And with my genetic counselor, Rachel, we stay in close contact with each other. But this is all part of this mutation, the importance of early detection. So I was thankful and honored for the opportunity to meet Dr. Lynch. And so, this way I can, continue his legacy to, educate the medical students, like I said before, about the importance of early detection, hopes of saving lives.
So, Rachel, if you can explain to us, we talked about Lynch syndrome, which got its name from Dr. Henry Lynch. Explain to us, what is a cancer syndrome, and beyond APC mutations that are linked to FAP, what other type of mutations or genes should patients or people watching this be aware of that might cause an increased risk of colorectal cancer?
Sure. So, an inherited cancer syndrome is essentially a higher risk for cancer because of an inherited what we call pathogenic variant or gene mutation is another common term. So essentially inheriting, or sometimes an individual's the first one in their family to have one of these pathogenic variants, it increases their risk of cancer over their lifetime. And there are different syndromes that kind of describe the underlying genetic or gene involved, underlying genetic mechanism, and then also somewhat describe which parts of the body, including the colon and the rectum, that might have a higher risk for cancer. So if you think kind of broadly, think about all cancer, the vast majority of it is not hereditary or genetic. So 90 to 95% of cancer is what we call sporadic or random chance. And so in these hereditary cancer syndromes, these are really a smaller portion of cancer that's caused by a strong genetic risk. And you mentioned already Lynch syndrome. We've talked about APC associated polyposis. There are other conditions that can increase risk for colorectal and other GI polyps and cancer, including juvenile polyposis syndrome, a condition called Peutz-Jeghers. And then there's also genes that are connected primarily to the stomach, like CDH1, which is a genetic risk for diffuse, what's called diffuse gastric cancer, so a specific type of gastric cancer. So, all of these are examples of scenarios in which a family has a strong risk factor. Again, typically that dominant pattern where there's a single gene mutation on one copy of the gene, but then the other copy of the gene is working just fine. And so it's this dominant pattern often in families where then they have this higher risk for cancer.
I'm reading this from the NCCN guidelines, Rachel. NCCN guidelines for patients, the colorectal screening guide. And we'll have this on our landing page at Genetics for Healthcare for this episode. It reads, colorectal cancer has always been thought of as an old person's disease. Now, studies have shown that a person born after 1990 is 2 to 4 times more likely to develop colorectal cancer compared to a person born in 1950. And it states because of this, it's very important to get screened at 45 years old. Let's talk screening for colorectal cancer. Who should get screened? What are their options to be screened?
Yeah, absolutely. And I'm glad you mentioned what we're observing in terms of younger people being diagnosed with colorectal cancer more often than we saw in previous generations. And I did want to point out that, that's not strictly hereditary or genetic, at least as far as we understand right now. I think there's many groups that are trying to figure out the why of that observation. But it's one of the reasons that now the recommendation is for everyone in the general population. So we're not talking about people with genetic risk or hereditary risk, or even those with family history of colorectal cancer. They would have slightly different recommendations. But those who are at general population risk for colorectal cancer, that they are recommended to start some type of colorectal surveillance starting at age 45. So Dan always tells his story, which makes perfect sense, that he got his first colonoscopy at age 50 because that was the recommendation at the time. And with this observation of younger people getting colorectal cancer, the recommendation is now 45 in the US. And that could certainly include a colonoscopy as one option. There's also stool-based testing. People have heard about Cologuard or other FIT-based tests. There's also some blood-based testing that has some really exciting data, and I think will be more widely adopted as well. So what the gastroenterologist I work with, and I think a lot of people in this field will say, like, the best screen is the one that gets done.
Sure.
So if you're not somebody who wants to do a colonoscopy and you have average risk, there are definitely other options for you.
With respect to screening for genetic mutations that increase your risk of colorectal cancer, germline genetic testing for all patients with a colorectal cancer diagnosis is now part of NCCN guidelines. But I recently had Dr. Ed Esplin on the podcast talking about how guidelines in some cases are not good enough because they miss patients who could benefit. But because they're not recommended or haven't been recommended in some cases by medical societies, clinicians may not offer it, they may not bring it up. For a person who is unaffected, they have no cancer diagnosis, who should consider talking to their healthcare provider or their PCP about genetic testing for hereditary colon cancers or hereditary cancer testing in general?
Yeah, great question, and happy also to circle back. Dr. Esplin is a good friend of and colleague of mine, and also of Dan's as well. So really happy to hear you had him on the podcast as well. So anyone who has a family history of cancer is somebody for whom a genetic counseling or risk assessment would be appropriate. So that would be a cancer focused risk assessment describing the family history, sometimes someone's personal history. So, for example, I see patients who they themselves have not had cancer, but they've had colon polyps, and we're doing a risk assessment related to that. Or if you've had a close family member with a cancer diagnosis, or certainly a cancer diagnosis yourself, that would be an appropriate scenario to see a genetic counselor. Now, recognizing that there's somewhat of a limited supply of genetic counselors across the US and certainly internationally. So, talking with another healthcare provider, talking to a gastroenterologist if it's GI focused, somebody who has some background and expertise in thinking about hereditary risk is important. And then in those scenarios, there may be a role for genetic testing. So, what you call germline genetic testing, which is basically looking at the inherited DNA to understand, is there one of these pathogenic variants or mutations that would increase somebody's risk? And many people ask, like, what is the purpose of knowing that? And it's really going back to what we were talking about with surveillance, right? If you know about a higher risk, specifically for the GI tract, for example, then we're going to have better options for surveillance. And that may be earlier surveillance at a younger age or more frequently. And so making sure that somebody gets what they need based on their specific kind of personalized, healthcare plan.
Is it fair to say that a lot of people that you talk to have reservations or anxiety about being tested? Talk to us about what is the actual process. Some people say, I don't want to give blood, or I don't want to, give my DNA. What are the misconceptions that patients have about genetic testing to determine a cancer risk?
Yeah, and I think there should be, an emphasis and a recognition of this being sometimes quite an emotional experience, especially if someone has had a loved one who has died from a cancer, or they themselves are going through cancer treatment, which in and of itself can be, very emotionally trying. So very important to recognize that and name that. Patients who come to see me, I mean, admittedly, they're probably a skewed population of people who take the initiative, ask their doctor, or their doctor recommends it, and then they schedule the appointment and show up for the visit, right? And so I think a lot of the time I see patients who are more motivated for genetic information. But certainly, the conversation does not mean that anyone has to do genetic testing. And I think that's where genetic counselors can play a really important role around education and providing patients with options, talking through what the benefits and the limitations are of testing, and then, recognizing that patients ultimately make their own decision about whether or not it's information they would like to have. And so, I see that as our role. I also recognize that there are probably people who have those reservations who, don't make it to a genetic counseling visit. Some very common misconceptions that come up are around parent of origin. And so sometimes, unfortunately, even medical providers and physicians are under the impression that cancer history, for example, breast cancer, is only important if it's on your mom's side of the family, which is absolutely incorrect. And of course, we get half of our genes from our dad's side and half of our genes from our mom's side. And so it's very important to look at both sides of the family when we're thinking about cancer risk. And it's also important to recognize recognize that sometimes we have this kind of genetic understanding of risk related to how we look. So, like, families will tell me, well, I look like this relative who had gastric cancer, so I must also have that same genetic risk. But in reality, these are genes that sort independently. They don't have anything to do with who we resemble in our family. And so certainly people can have gut feelings about whether or not they inherited a risk, but the scenario is that they're all sorting independently. And I'm sure there's other, common misconceptions that come up as well. But I think, recognizing that this is emotional and can be difficult, but also knowing that there's a lot of benefit as well, and trying to make sure we're helping and partnering with patients through that process.
Wow, that is so rich. Thank you for breaking it down like you did and talking about those misconceptions. Dan, when we talk about, we just got to talking about screening and the options, and the best option is the one that gets done. According to the Colon Cancer Coalition, the national goal for colorectal screening is 80% in all communities. But currently, the US has approximately a 59% screening rate. How do you manage the psychological and emotional aspects of living with a hereditary cancer syndrome?
Well, it all goes back to my military experience, especially my 4 deployments to the Persian Gulf. Like I mentioned earlier, plan for the worst, hope for the best, adapt, improvise, and overcome. So, prior to going to the Persian Gulf for these deployments, you have to do preparation, lots of training with your comrades on the ships. So when I was informed about this diagnosis, I went into battle mode in a positive way, where I was able to gather information so I could make a logical decision based on the information I was being provided. Now, of course, I didn't know that my genetic counselor and colorectal surgeon were colleagues of Dr. Lynch, and I was already ready. I was on board with all this from the beginning. My mindset was, which it still is, I tend not to think about things I'm unable to control, such as medical concerns, medical issues. What I can control is my positive attitude. And after 6 decades on God's green earth, it's brought me this far. Why change now? So I just wanted to gather, I continue to want to gather as much information. I asked Rachel, I ask her questions, often, because I'm like there's like baseball players that are a student of the game. Well, I mean, I consider myself a student of this, mutation. I want to learn more. I want to, what's next? I mean, we don't know. No one knows. I mean, but however, the surveillance is the important piece to it, and so I'm open to all that. I mean, I learned many decades ago, in life we have two choices: we can react or we can respond. And by responding, we gather information that we can make a logical decision, like I mentioned earlier. By reacting, we may make a rash decision we may later regret. So this is how I wanted to gather information to read about what this diagnosis is, and then what the type of surgery, and then having a permanent ostomy. So there's a lot of things going on here. A lot of communities that I've been involved with, the hereditary colon cancer community, the ostomy community. It's a rare disease, so I've been involved with a rare disease, men's mental health. So I can pick and choose. However, it gets back to wanting to educate the medical students about the mutation. So that's what keeps me going, And I continue to be asymptomatic. I mean, it just this whole thing is all mind blowing, really. And but I enjoy this journey. I've enjoyed it from the beginning, and I've learned a lot. Like I said, I continue to learn. So the psychological part, I mean, my military experience had helped me, be able to. My positive attitudes helped me to overcome adversity. So that's
Yeah, I can sincerely appreciate that. I'll get you guys out of here on this. At Genetics for Healthcare, we always want to leave our viewers with practical tips with the information that we share that might be actionable. So, Rachel, for families who have they suspect that they may have a hereditary cancer syndrome, what are three practical tips for approaching genetic testing and conversations with family members, their care providers, and getting to an appointment with genetic counseling, not only for themselves, but for other relatives?
Yeah, thanks, Roman. I appreciate that question because I think sometimes it is tricky with family dynamics. What an individual might choose is different than what a family member might choose. And sometimes that can be, a complicated conversation. I did also want to just comment on the resources that Dan mentioned because I think that would be one of my practical tips for families and individuals who are going through this process. Is there's some great advocacy groups specific to hereditary colorectal or other GI cancers, and so I would certainly recommend that they seek out peer support. So if they have a known hereditary cancer condition, there are support groups that are focused towards that. So for example, for Lynch syndrome, there's an organization called Alive and Kickin. There's also a broader organization called Fight CRC that's really focused on colorectal cancer advocacy. I'm sure you're familiar with some of their work. And then there's also a hereditary cancer support group that's kind of more broad, a national group called FORCE, Facing Our Risk of Cancer Empowered. And so they have individual kind of focus groups depending on, an individual patient's background. So if they have Lynch syndrome or they have hereditary breast and ovarian cancer, or even if they're a caregiver of somebody. And so I think one of the practical tips is certainly seek out or ask your genetic counselor for recommendations for groups that might be relevant for you. For families who don't know if they have hereditary risk or they're interested in learning more, I think certainly genetic counseling can be a great first step because that's really our job, is to help them walk through that process, understand whether or not genetic testing is valuable. Sometimes it is, sometimes it's less so, and kind of walking them through that process. My third kind of practical tip, let's say, is have as many open conversations about family history as you can. Thanksgiving is actually National Family History Day. It's one of those things where we kind of talk up of like, you're sitting around the Thanksgiving table, ask about family medical problems. Like that's just not something that where the conversation flows as easily typically. And so ask what your grandfather died of, ask what his brother died of, right? These are things that just don't come up as easily. And so getting educated around your own family's history certainly can be more effective when you see a genetics provider, so you can more accurately, describe the family history. But I think you learn something that then, of course, can be useful for your own surveillance and recommendations for your own, cancer avoidance, if you will. Really, we're all in the business of cancer prevention.
I appreciate you sharing that. All of the groups that you mentioned and Dan had mentioned, you can go find those links to these patient advocacy groups and support resources on Genetics for Healthcare on the episode page for this podcast, wherever you might be listening to this. Dan, for those folks who are out there who are inspired to get tested, what are three practical tips that you would give someone who might be hesitant, or they have been tested and discover that they have a high risk genetic mutation, like an APC variant? What uh, practical tips or really encouragement would you give them in the management and follow up of this information?
Well, that's a great question, Rome. I created an acronym for the word ADAPT shortly after my diagnosis, and that's attitude determines the ability for a positive transformation.
Got to write
So
that down.
I live by that. These are just the things that come up. So being able to adapt, going talking to your family members and your medical team ask questions, especially your medical team. There's there's never enough questions that you can ask, and it goes back to my military experience. Equipped me to adapt, improvise, and overcome. So adapt, ask your medical team questions, and my mantra: always forge ahead with a purpose.
Absolutely. Dan Dry Dock Shockley, U.S. Navy veteran and cancer prevention warrior, and Rachel Hoden, genetic counselor and associate professor of genetics at Stanford University. Before I let you go, Dan, you got to tell us where Dry Dock come from, because I can't say your name without saying Dry Dock in the middle. So tell us about that.
That's what it's all about. Yeah. Well, in the Navy, I was on 7 different ships, and come back from deployment. 2 of them had gone into dry dock, and dry dock is where a time where that ship is going through extensive maintenance and upgrades and what have you, bring it out of the water so they can, take a look at everything. And so I was in Hawaii. I moved to Northern California to be closer to Palo Alto VA and Stanford, because my surveillance as I got older, I knew I was going to be inevitably I'd be at Stanford for surgery. So while I was up in the Sacramento area, about 5-6 years ago, I signed up. I heard about this vintage baseball club up here in Sacramento, and they play by 1863 rules. So, back in the Civil War era, um, no gear, and just all type of different things. Of course, when baseball first started. So I signed up. I was interested. I showed up, and they actually put me in the lineup to play for one of the teams, and I'm like, well, I'm just wanting to watch. And oh yeah, what position will I play? Oh, we'll play first base. Okay, so it put me down first base. The second baseman, his name is Dan, so he had Dan first base, Dan second base. So I went up to the coach before the game started. I said, hey, you might mix this up a little because you got 2 Dans here on the right side of the infield. He goes, well, that's a good question. We recommend our players to have vintage themed nicknames. And I said, okay, right off the top of my head, I said, just call me Dry Dock. I'll tell you later. So I told him, when I joined the Navy, my home of record was Illinois, the land of Lincoln. And we're playing by 1863 rules, which is the Civil War era. Abraham Lincoln was president. And one of those ships that I came back from a deployment and went into dry dock was the USS Abraham Lincoln. That's my story, and I'm sticking to it.
Dan Dry Dock Shockley. Dan, I appreciate your spirit, your advocacy, and your attitude to always forge ahead with purpose. Thank you both for being a guest on Genetics for Healthcare, a podcast for patients.
Thanks, Rom.
Thank you very much. Thank you, Rachel, for taking time out to be part of this awesome interview.
Of course. Happy, as always, to work with you, Dan, and great to meet you, Rome. Thanks for all the work that you do, too, for patients.
Absolutely.